I would request Leila madam to give her a pediatric opthal perspective on lacrimation.
Thank you, Dr. Saumya, for giving me the opportunity to be part of this session. So, is it on? So, all the most common cause of lacrimation or epiphora, as shown by Dr. Anju, is the commonest situation where we get tearing child with watering. So watering in an infant brings us to a more serious problem where lacrimation, photophobia and blepharospasm together, what we call the triad, where we have to doubt a more serious problem of intraocular pressure being high and enlargement of the eye and cornea which may be asymmetrical when the child is brought immediately, but when it is symmetrical, they may not bring the child immediately. Some watering may be overlooked, and when the cornea becomes hazy, only they will notice. So that is the importance of asymmetrical. They bring immediately. When it is bilateral, it is more difficult to diagnose. And when there is corneal haze, abnormally deep anterior chamber, in children usually it is very shallow anterior chamber. So when it is abnormally deep and all these features are there, then it is not difficult to diagnose congenital glaucoma. But when the classic features are not there, then we have to take all precautions to diagnose quite early, because surgery is warranted. It is an urgent step to be taken after complete evaluation and diagnosis, coming to a conclusion. So, so already she has pointed out, Dr. Anju has pointed out all the causes for epiphora. You have seen the lid abnormalities, conjunctivitis, nasolacrimal duct obstruction, the commonest, corneal exposure producing blepharospasm also sometimes. So photophobia, when there is any corneal problem with foreign body, corneal aberration, these are the commonest problems which we come across. Birth injury can also produce a tear in the Descemet's membrane and corneal edema. And uveitis, light scatter by media opacities, especially cataract in a child, can produce photophobia. And large cornea, of course, it may be a megalocornea, or axial myopia can also present with the larger cornea and the eye, and anterior megalophthalmos or keratoglobus, which appear like a ophthalmos. Corneal opacities, the commonest is corneal congenital hereditary endothelial dystrophy, where you get a bilateral picture of endothelial dystrophy, stromal opacity also will be there. Sclerocornea, Peters anomaly, infectious keratitis in a child, forceps injury, as we have seen already, it will produce a corneal opacity at the time of birth. And mucopolysaccharidosis, which comes little later. So during clinical examination, a proper family history and the time of onset of the enlargement of the eye or photophobia watering has to be taken. And in an older child, we can also see fixing and following nystagmus is there or not, whether it has affected vision, asymmetry of the size of the cornea and aversion to light, and the slit lamp examination if the child allows you to see the anterior chamber. And glaucoma, if it is diagnosed earlier than within a month of birth, it is called neonatal, which has a poorer prognosis, and 1 to 24 months it is called infantile, and above 2 years it's a late onset congenital glaucoma. So the other associations have to be looked for: iridotrabecular dysgenesis like aniridia, Peters, Rieger's, rubella, Lois and Lubinstein type B, where they present with cataract. We have to also look for high IOP, and sticklers, where you have to look at the retina also. Iris hypoplasia also can produce glaucoma, and some of the Sturge-Weber and other manifestations are very obvious to us at the time of presentation. And it's very important to diagnose the children with congenital glaucoma immediately. So an examination under anesthesia is the best. If it is not under anesthesia, we can see a sleeping child after fasting for 2 to 3 hours. We can ask the mother to feed the baby and then look at the eye, and also intraocular pressure can be measured if it is possible to give it will avoid another anesthesia immediately after, before as the second procedure of surgery. So the order of examination, we do laryngeal mask anesthesia when we do EUA separately. If you have a clinical diagnosis, then you can go ahead with intubation and you can have the examination under anesthesia just before doing surgery to know what is the corneal diameter. All these have to be seen definitely before surgery. So the order of examination in examination under anesthesia or a sleeping child will be IOP before deep anesthesia, especially when intubated and deep anesthesia is there, there will be a lowering of IOP. So before intubation and before struggling for intubation also, it's preferably before intubation if you are giving an intubated anesthesia. So slit lamp examination, corneal diameter, the horizontal white to white examination, fundus examination if it is possible, gonioscopy and refraction, axial length, also a pachymetry can be done, and ultrasound axial length examination and B-scan if the posterior segment could not be visualized, and in case of atypical findings this may have to be repeated. I'll go through fast. IOP is very important, that is the, as we have seen, we have to see under anesthesia or a sleeping child. Perkins is best. Tonopen gives a higher reading, and in infants usually we get 10 to 12 millimeter is the usual reading we get, and so higher than that we have to be very cautious. Sometimes these anesthetics, ketamine and succinylcholine produces a higher reading, and the IOP should not be adjusted for pachymetry. And IOP should not be definitely taken as the criteria to diagnose also. Fundus examination, a cupping of more than 2 is suspicious, and asymmetry of more than 2.2 is also suspicious, and after surgery this cupping may be reversible, but you have to follow up. And some of the differentials are coloboma and morning glory syndrome. And gonioscopy in a child is a very widely open angle, but translucent, looks translucent. It can be either direct or indirect gonioscopy, and the usual pattern in congenital glaucoma is a high insertion of iris and ciliary body covering the trabecular meshwork, which gave the appearance of a membrane, and Barken's membrane was the concept before. And a flat iris surface is also seen. Look for other developmental abnormalities like iris rigors and other pathology may be there. And this is corneal diameter should be looked for. At birth it is less than 10.5 is suspicious. More than 11 millimeters you have to be very suspicious in a child at birth, and more than 11.5 millimeter by 1 year, and more a diameter of 1 millimeter above this standard norms for a child has to be suspiciously looked at. And glaucoma should be suspected in any child with corneal diameter above 12 millimeter at 1 year or more than 13 millimeter at any age. And Habs tray should be looked at with a slit lamp, and scleral thinning may be also there. And Desmond's tear in a forceps delivery, it usually presents with a vertical rupture, and in glaucoma it is usually a circumlinear or a horizontal. Axial length at birth it is usually 16.7 to 17, so above 18 has to be considered abnormal, and it has to be serially measured if you suspect glaucoma. And refractive errors are very, very common. This child had a surgery, she presented with eye drops in one eye, and IOP was very high, and look at the cornea, which is shows dense opacity, so we couldn't do goniotomy, which is ideal if cornea is clear in a child. So anisometropy is very common even before surgery or after surgery, and rapid myopic refractive shift and elongation should be looked at, and amblyopia definitely should be treated even before starting treatment, and patching instituted as soon as possible. This is a post-conjunctive conjunctive cataract surgery where the child was microphthalmic. It was a microphthalmic child presented with a ophthalmos later with watering and photophobia. So management, of course, medical management is temporary, and choice of surgery depends upon the clarity of surgery, clarity of cornea. And angle surgery is the best if cornea is clear, when we can visualize the trabecular meshwork and the iris angle. So ab interno or ab externo 360-degree trabeculotomy may be done with a suture or with an illuminated catheter, and combined trabeculotomy with trabeculectomy is the most possible when cornea is opaque, and later if it is not working we may have to do an tube shunt. So follow-up is very, very important. It has to be continued even after surgery, and the size and clarity of cornea need to be frequently assessed in a neonate, and EUA may be necessary if the child is not cooperative. Sorry for taking that time. I hope we finish before our general body. Thank you.
Thank you so much, ma'am, for that detailed talk on glaucoma and neonates.